This is QD Clinic. QD Clinic is brought to you by RheumNow's coverage of ACR 2023. We'll be in San Diego. Follow us. Today's case is a patient who I was going to call a no-show, won't go, but she's really a habitually non-compliant patient. The question is what to do. At last visit, she's 33. She has seronegative RA that looks like it dates back for, I want to say maybe, where is that? About 3 or 4 years. She's been tested several times for serologies and always negative. But at presentation and since, she has had a chronic polyarthritis, usually symmetric, usually somewhere around 2 to 5 joints. She's had involvement of the MCPs, PIPs, knees, left elbow, left wrist, occasionally a finger. She has all-day morning stiffness when I see her, and her labs were remarkable for an elevated SED rate of like 63. So her story is, over the last 3 years, I've seen her about 4 or 5 times. Between this visit and the last visit, it's been almost a year and a half, right? So I would see her and then she wouldn't come back. I'd see her again and she wouldn't come back. And why she wouldn't come back is I would each time prescribe therapy for her RA, and she was always reluctant to do that. So, and the question is, what do you do when someone just keeps coming back and asking for help? Each time she comes back, she always has active disease. And then she always says that in between, she's doing very well. But again, she always has swollen joints, morning stiffness, etc. She has no other medical problems. She hardly takes any medicine at all. In the past, I have prescribed for her leflunomide and prednisone and methotrexate. And hydroxychloroquine. At one time, I think you talked about etanercept. I don't believe she's taken any of those. She outright says, I don't want to take prednisone because I may gain weight. I don't want to take methotrexate because then I'd have to stop drinking. This is a young, healthy woman who is successful in her business, is highly social. She wants to look good and play hard and be the girl around town. And the story she's telling herself is that she doesn't have rheumatoid arthritis, except for intermittently, and I see Dr. Cush, and he fixes it with a shot or something. And so I keep telling her, this to me looks like it's chronic. You tell me it's intermittent. I don't know. She says in between she's active with exercise and going to the beach and traveling, etc. Anyway, on this visit today, she complains of pain, stiffness, swelling in her left elbow and her fingers, and also her left jaw. Morning stiffness is all day. On exam, she has 8 tender and 4 swollen joints. The 4 swollen joints being left MCP1, left wrist, left elbow, and a knee, and she has bilateral Baker cyst, worse on the right. So she has like a CDI score of 16. In my clinic, that's a global arthritis score of 16. And she has a left elbow contracture. And today she wants an injection in the elbow. So we talk about her treatment options. She does get a left elbow injection. And again, I offer to her, let's restart the leflunomide, or let's go back on daily hydroxychloroquine. And she has to get eye exams for that. She doesn't want to do that. Or we can put her on adalimumab and get a shot every 2 weeks. And she agrees to the adalimumab, she agrees to the injection, but I know, actually, since I saw her, she has not returned. And that's over 8 months ago. So the question is, what do you do with someone who's habitually non-compliant and you're really not sure if they're taking any or all medicines, or that you're really not following your advice? Number one, you need to create trust with the patient, right, so that they will listen to you, as opposed to creating their own story. And the story in her head is that she has intermittent arthritis, not rheumatoid arthritis, that will maim, disable, and harm her. And you don't want to be doom and gloom, but the fact is she has numbers and chronicity, and RA is always progressive. RA is always damaging. And that's going to happen no matter how young or active she is. So my rules on people like this are, number one, only give them a plan, give them an explanation. So again, hope, goals, and rules, right? Give them hope that they can get better and avoid taking aggressive medicine if possible. The goals and rules I've told her. And then next, you only give her enough prescription medicines so that she's going to have to come back to you, or she's going to have to go to somebody else. And it could very well be that she's seeing other doctors to supplement her arthritis needs, and she plays one against the other. But I don't know about that. I have no evidence of that. Again, she likes me, and I think she's very honest with me. I mean, she tells me, up front, I'm not taking prednisone, I'm not taking methotrexate. I think I impress upon her that, maybe Humira, it might be a good option in her. But the next option really is you only give medicines that you can guarantee that they are administered, which means it's an infusion therapy. No self-injectables, no self-administered, nothing that requires, as little as you can do that requires even laboratory monitoring. So if it's going to be an infusible medicine, my choices for her would be either tocilizumab, abatacept, or rituximab. And I would sort of present it in that order. And then the last thing I do in people like this is I give them some form of analgesic relief. And I gave her a prescription for celecoxib, 200 milligrams QD, maybe increased to BID, always with meals. And then lastly, since this is the second injection I've given her, you spell out the rules on steroid injections. My rules are, I can inject the joint every 6 months. I can inject the same joint twice. After that, I'm going to be pushing back because I don't want to do 3, 4, 5 Q6 month injections in a knee or an elbow or anything else. I think that's just a bad idea. Basically, you should be treating the condition so that you don't need to do joint injections. That's it. That's how I would manage the habitually non-compliant patient. Again, ACR is coming up. If you want to know a great way to consume the ACR, we gave you some tips in the first 2 QD clinics. My next tip is going to be Rheumatology Roundup. Dr. Artie Cavanaugh and I have been doing Rheumatology Roundup for over 15 years. ACR stopped us doing it about 2 years ago, but we still do it on Rheum Now. In 1 hour, we'll cover, it's going to be live streamed next Friday, which would be, I guess, the 16th or 17th. It's going to be at 3 p.m. Pacific time, and it's going to be November 17th, 3 p.m. Pacific time, 6 p.m. Eastern time. We're going to have a live stream of Cavanaugh and Cush doing Rheumatology Roundup, where we give you our highlights. We'll cover what we think are the 15 or 16 best abstracts from the meeting. It's infotainment at its best. Be sure to tune in. And if you're not there for the live stream, you can actually listen to the recorded event either on video or on podcast. Tune in for more QD clinics during ACR week.